Hi friends, we will try to cover important topics and previously asked question of biochemistry. First question which was asked in NEET 2022, that nonsense mutation, you all know that there are 64 codons, 64 codons. Out of 64 codons, 3 stop codons are there. UAA, you are away, you are gone, you go away. These are 3 stop codons. Whenever a codon is replaced by stop codon, that is called nonsense mutation. Okay, so suppose this is UCA code for serine. Even if you don't remember, it's okay, just remember UCA code for some amino acid. For the time being we know serine. If this UCA is converted to UAA is stop codon, UA is stop codon. This is a nonsense mutation. We found that 61 codon code for 20 amino acid. You all know there are 20 amino acid which usually take part in protein synthesis. So if you take average 61 divided by 20, you will find 3. So one amino acid on an average is having 3 codons on an average. Means more than one codon for single amino acid, more than one codon for single amino acid. This is called degeneracy of codon. This is called degeneracy or redundancy of codon. Okay, so codons are degenerate. That's the reason that silent mutation is possible. What is silent mutation? Suppose this is messenger RNA, this is messenger RNA. In this messenger RNA, at this position, there is UCA code for serine. And if this messenger RNA will take part in protein synthesis, at this point, a serine amino acid would be there. Now mutation occurred. After mutation, this UCA is converted to UCU, again code for serine. We found that one amino acid coding for serine is replaced by other codon. Yes, coding for serine means one codon coding for serine is replaced by another codon coding for serine. This is called silent mutation. If this messenger RNA will make a protein, it will have serine at the same position. Means in silent mutation, primary structure of protein remains same. Primary structure of protein remain same. This is important question. Okay, so redundancy or degeneracy question can be asked that silent mutation is possible because codons are degenerate. Why I'm telling you? Because they have asked one question about Wobble hypothesis. Wobble hypothesis is possible because of degeneracy of codon or redundancy of codon. Recently asked question. Suppose this is messenger RNA, this is transport RNA. First question, how many transport RNA? 31 transport RNA are there for 20 amino acid. Means one amino acid is having its own transport RNA. But one amino acid may have more than one transport RNA. Yes, but each and every amino acid is having its own transport RNA. Now, 20 amino acid, 31 transport RNA, 61 codon. So if you take average 61 codon for 31 transport RNA, this is transport RNA, this is messenger RNA. Messenger RNA is having codon, transport RNA is having anticodon. Point it out. Codon recognize anticodon or anticodon bind with codons. So transport RNA is having anticodon. Now, suppose this messenger RNA is having two codon, UCA and UCU. We found that this transport RNA is only one. Yes, suppose serine is having only one transport RNA and two codons. What will happen? This transport RNA will come. A will bind with U, G will bind with C, U will bind with A. Yes, no problem. Second transport RNA will come, A will bind with U, G will bind with C. U will not be able to bind with U. Can it be possible? Yes, Vobel hypothesis. Vobel hypothesis says that abnormal base pairing. Vobel hypothesis. Vobel hypothesis says that abnormal base pairing can occur between third nucleotide of codon. This is 5 and this is 3 end. Third nucleotide of codon and first nucleotide of anticodon. Got the point? This is Vobel hypothesis. Question was asked, recently asked, that Vobel hypothesis is possible because codons are degenerate. Codons are degenerate. So two question. Codons are degenerate, that's why Vobel hypothesis is possible. Codons are degenerate, that's why silent mutation is possible. Okay. Now, frame shift mutation, you must remember that frame shift mutation occur when one or two nucleotides or multiple of one or two are inserted or deleted. Means if I delete one nucleotide, then there would be frame shift mutation. If I delete two nucleotide, there would be frame shift mutation. But if I remove three nucleotide, this is not frame shift, not frame shift mutation. Question is asked in such a way that they will give that there is a nucleotide sequence in this three nucleotides in a sequence are removed. This mutation is frame shift, yes or no? No, it is not frame shift mutation. Got the point? This is so frequently asked question. You all know fatty acid bind with sphingosine to form ceramide. Normally in our body, ceramide is metabolized by ceramidase. If ceramidase is deficient, then it is called Farber disease. Then it is called Farber's disease. Farber as barber. Farber as barber. Now, if a barber is cutting the hair of sir, ceramidase sir के बाल काटता है, yes, whole day he would have joint pain just like rheumatoid arthritis. So Farber disease, there is frequently asked question, clinical question. They will give multiple symptoms and they will give that the patient is having rheumatoid arthritis like joint pain. The answer would become yes, Farber's disease. Now, ceramide bind with glucose to form glucoceramide. Yes, ceramide can bind with galactose to form galactoceramide. Okay, glucoceramide is metabolized by beta glucosidase. If this enzyme is deficient, then it is Gaucher's disease. Gaucher's disease. In Gaucher's disease, you will find that multiple non-neurological symptoms are there. Means nervous system is not affected because glucocerebrosidase is found in extraneural tissue. That's why you will find that hepatomegaly is there, splenomegaly is there, bone marrow infiltration would be there, there would be anemia, thrombocytopenia, platelet will decrease. These types of symptom would be there. These types of symptom would be there and they will give that there is typical crumpled tissue paper appearance. Crumpled tissue paper appearance. So many times same question I have given this. They gave recently in neet, they gave different symptom. Thrombocytopenia is there, anemia is there, hepatosplenomegaly is there, and they give histopathological picture, crumpled tissue paper appearance. The answer was Gaucher's disease. Yes, Erler-Meyer flask deformity. This is Erler-Meyer flask deformity. Point it out. In all mucopolysaccharide, sorry, not mucopolysaccharide, sphingolipidosis. On sphingolipidosis, I am going to discuss all these. You will find mental retardation, but Gaucher's disease Gaucher disease, no mental retardation. This is very, very important catching point in many clinical questions. Galactocerebroside, galactoceramide is metabolized by beta galactosidase. And if beta galactosidase is deficient, then it is Krabbe's disease. Krabbe's disease. In Krabbe's disease, there is cherry red spot, there is globoid cell. Okay, we found that ceramide bind with phosphate plus choline to form sphingomyelin. This sphingomyelin is normally metabolized by sphingomyelinase. If sphingomyelin is deficient, then it is Niemann-Pick disease. Niemann-Pick disease. And in Niemann-Pick disease, there are bubbly appearance, foamy appearance. I usually remember neem soap. If you are not taking bath for a long time in winters and you take bath, you will find this type of, yes, bubbles. Okay, not so good. Yes. And zebra bodies. Yes, I usually make mnemonic, Baba Ramdev's neem soap is very effective. If you take a zebra and, yes, make him bath with Baba Ramdev's neem soap, it may be converted into donkey. Okay, all the stripes will be gone. Yes, that is zebra bodies. Hypothetical story I made. It will help you to remember. Yes, few questions are asked. Farber disease, ceramidase, I just discussed. Fabry's disease, Fabry's, alpha galactosidase. Yes, beta galactosidase was Krabbe's disease. Alpha galactosidase, Fabry's disease. Alpha looks like X-linked recessive. All other sphingolipidosis are autosomal recessive, but Fabry's disease is X-linked recessive. Mnemonic TSH disease, hexosaminidase A. Sandhoff disease, T4 TSX, H4 hexosaminidase. Sandhoff, S4 Sandhoff, H4 hexosaminidase A and B. How you will remember A and B? How many F are there? Two F are there. Yes, two letters, similar letters, Sandhoff disease. Now, Gaucher disease, beta glucosidase, Niemann-Pick disease, sphingomyelinase, metachromatic leukodystrophy. I usually remember aerial. Yes, surf. Aerial surf. If you see the aerial advertised was there, there were so many granules of different color. Metachromatic, different color. Leukodystrophy. Leuco means white. Okay. Exact color of aerial is white, but multiple color granules are there. Acid life. Next topic is very, very important. Electron transport chain. This is outer mitochondrial membrane. This is inner mitochondrial membrane. Yes. At inner mitochondrial membrane, there are enzyme complexes. This is complex 1, 3rd, and 4th. Complex 1 is also called NADH coenzyme Q reductase, inhibitor of complex 1, ONE1, rotenone, rotenone, pyridine. Question is asked. Cytochrome C reductase complex 3rd, fenformin inhibitor, fenformin, metformin. Oral hypoglycemic drug. Question is asked. Fenformin is not used nowadays because of lactic acidosis. If electron transport chain is inhibited, that may cause lactic acidosis. Cytochrome C oxidase, multiple time question. You must remember their inhibitor. Yes, carbon monoxide, cyanide, H2S, azide. In this, most frequently questions are asked on carbon monoxide, cyanide. Okay. This is cytochrome C, which is present at inner mitochondrial membrane and take part in electron transport chain. But if this cytochrome C dissociate from inner mitochondrial membrane and this cytochrome C comes at cytosol, yes, if it comes in cytosol, it start apoptosis. So question is asked, Cytosolic cytochrome C mediate, the answer is apoptosis. In the same question, if they remove this cytosolic word, only they say cytochrome C mediate, the answer would be electron transport chain. Okay, we found that this is complex 5. Complex 5 is made up of two part, F0 and F1. F0 is HN channel, this F0 is HN channel, and F1 is having ATP synthase activity. It convert ADP to ATP, and this F0, sometimes FO, is inhibited by oligomycin. Oligomycin, question is asked, oligomycin inhibit complex 5. Which component of complex 5? FO, F0. Clear? Question was asked, conversion of ADP to ATP is inhibited by oligomycin. Now, look at this brown structure. This is ADP ATP translocase. What is the function of this translocase? You can remember translocase. Look at me. Suppose this is translocase. One thing bind at this side, one thing bind at this side. It rotates. So ADP bind at this side, ATP bind at this side, ADP in, ATP out. So ADP ATP translocase transfer ADP in, ATP out, and atractyloside inhibit ADP ATP translocase. So question is asked, ADP ATP translocation is inhibited by, then atractyloside, ADP ATP translocation, and ADP to ATP conversion is inhibited by oligomycin. Both of these are not uncoupler. Uncoupler is a different entity. Any compound which cause HN leakage. Yes, uncoupler means any compound which cause leakage at inner mitochondrial membrane is uncoupler. Any compound which cause HN leakage at inner mitochondrial membrane, question was asked, 2,4-dinitrophenol. 2,4-dinitrophenol is going to produce whole, phenol produce whole, that is uncoupler. Okay, natural. What is natural uncoupler? Thermogenin, thyroxine, long chain fatty acid, unconjugated bilirubin, these are natural uncoupler. Usually questions are asked on thermogenin. This is natural uncoupler found in brown fat. Brown fat. Okay, and responsible for non-shivering thermogenesis. So these are the questions on electron transport chain. All the complexes of electron transport chain transfer HN from mitochondrial matrix to intramembranous space. This is very, very important. Complex 1 transfer 4HN. Complex third transfer 4HN. Complex 4 transfer 2HN. While complex 4 transfer 2HN, while complex 2 transfer how many HN? Yes, you know, 0 HN, no HN. When it transfer no HN, it contribute no ATP. Question is asked, complex 2 is succinate coenzyme Q reductase. It transfer how many HN? 0 HN. So it produce how many ATP? 0 ATP. Okay. Now, so this is electron transport chain. Mucopolysaccharides. Recently asked question. Mucopolysaccharide is having acidic sugar, amino sugar. Even if you don't remember anything, just remember that any mucopolysaccharide absorb large amount of water. Absorb large amount of water to form mucoid structure. Chi wala. Okay, mucoid structure. So these mucoid structure has shock absorbing property. So hyaluronic acid, creatine sulfate, heparin sulfate, chondroitin sulfate, dermatan sulfate, they are glycosaminoglycan or mucopolysaccharides, and all these have common structure except hyaluronic acid has no sulfate. No sulfate. If question is asked and they gave you structure and you found that this structure is given, just like Ames question was asked, this structure was given and you found no sulfate, there is no sulfate in this, So the answer is hyaluronic acid. So if question is asked, they gave the structure, you will search for sulfate. In this question, if they gave this structure, sulfate is there, it can't be hyaluronic acid. Question is asked, hyaluronic acid, no sulfate. Sulfate, it can't be hyaluronic acid. Sulfate, it can't be hyaluronic acid. No sulfate, no sulfate, hyaluronic acid. Okay, so first question, hyaluronic acid has no sulfate. If they gave structure, you will search for sulfate. If no sulfate, hyaluronic acid. Second thing, you will search for COOH, uronic acid. A uronic acid or simply acid. If acid is absent, then it is keratine sulfate. Keratine, कीर्तन, wherever you do कीर्तन वहां पे यूरिनल नहीं बनाते, तो keratine sulfate, no uronic acid. Suppose they gave the structure, suppose they gave this structure, okay, and you found no COH in this structure, you, this is keratine sulfate, there is no COH in this structure. Heparin, if you see the structure of heparin or chondroitin sulfate, you will find COH. You will find COH. If COH is there, it can't be keratine sulfate. All glycosaminoglycans, mucopolysaccharide are found extracellular, but heparin is in for intracellular. Recently asked question, keratine sulfate is responsible for the transparency of cornea. Transparency of cornea. Okay. Hyaluronic acid is found in vitreous humor, synovial fluid. Vitreous humor, yes, is eye. Cornea is eye. A question was asked combination. Yes, vitreous humor and cornea. Yes, both are part of eye. Which of the following glycosaminoglycan are found in eye? One option was given, hyaluronic acid plus keratine sulfate. Got the point? Now, mucopolysaccharidosis. In all mucopolysaccharidosis, you will find more or less same features, just like coarse facial features, frontal bossing, yes, large tongue, depressed nasal bridge, corneal opacity, yes, dysostosis multiplex, multiple bones are affected, bullet-shaped fingers or phalanx, better to say, yes, mucoid nasal discharge, copious nasal discharge. These are mucopolysaccharidosis. How you will solve the question? If they gave this clinical question and you found that they will give iduronidase is deficient and this is complete deficiency. Complete deficiency. Answer would be mucopolysaccharidosis type 1, Hurler disease. If they say partial deficiency, yes, she, partial deficiency, she disease. If complete deficiency, mental retardation. If partial deficiency, no mental retardation. Many times they will give clinical question, they will give you the name of enzyme and they will mention that mental retardation is not there, and the answer would become she disease. Hunter's disease, you all know Hunter's. Yes, you must have seen many movies. Hunter, two guns are there, face of lion. Yes, this is Hunter. Two guns looking like X. X-linked recessive. X-linked recessive. So if X-linked recessive more common in male than female. Hunters are usually male. You must have heard a song. Yes, मैं हूँ शिकारी कुड़िए खाली मेरा वार न जाए. शिकारी कौन है लड़का है. More common in male. Okay. Although some duck questionnaires are also there, but X-linked recessive hunter's disease. If you are going for hunting, your corneal opacity should not be there, your vision should be clear, otherwise you will be hunted by lion. Okay, so nature is very wise, or we are very wise, we named it in such a way, hunter's disease. No corneal opacity, no corneal opacity. Okay, and the name of enzyme deficient is iduronate sulfatase. Simply 1 MPS 1 word is deficient, iduronidase, one word is deficient. Yes, MPS type 2, two words are deficient. More Q disease, more IQ. More IQ means no mental retardation. They are not intelligent, but there is no mental retardation. San Filippo, sub may, S for sub, means most common. These are common question. Okay, you can solve this question very easily. Yes, 12-year-old intellectual disabled, MR is there. Okay, short stature, protuberant abdomen, umbilical hernia, prominent forehead. His vision is normal. If vision is normal, it is Hunter's disease. Which enzyme is deficient? Iduronate sulfatase. Next is every time same question again and again, tryptophan. So many questions on tryptophan. Tryptophan deficiency is common. Who टेक लार्ज अमाउंट ऑफ मेज, मजे नहीं लेना। यस, मजे आ गए। देखते हैं मजे आएंगे क्या। ट्रिप्टोफैन इज हैविंग इंडोल रिंग। इंडोल इज बेबी डोल, बेबी डोल में सोने की। दिस इज सो बल्की रिंग, हैवी रिंग। ओके, ट्रिप्टोफैन, ऑल फैंस आर ट्रप्ट। Tryptophan, all fans of Sunny are trapped. Okay, now tryptophan give rise to niacin. 60 milligram of tryptophan give rise to niacin. If tryptophan is deficient, there would be niacin deficiency, and if niacin deficiency, there would be 3D: diarrhea, dementia, dermatitis. Diarrhea, dementia, dermatitis. Yes, dermatitis, typical Castle-Neck appearance. Typical Castle-Neck appearance. So if any question you find Castle-Neck appearance, the first answer will come in mind is niacin deficiency. But this niacin deficiency may be due to multiple reasons. Just like if tryptophan is deficient, yes, patient is not having tryptophan, it will not be able to convert it into niacin deficiency. There are multiple steps in this conversion. Any step is deficient, then there would be niacin deficiency. We found that if B6 is deficient, then niacin will not be formed. Niacin will not be formed. If niacin will not be formed, that is pellagra. That is pellagra. So pellagra may be due to this. This typical picture may be due to B3 deficiency. In this question, answer is B3 deficiency. Yes. In the same question, if they gave xanthuronic acid is increased, what I said, 6 cross, okay, xanthuronic acid, make any mnemonic here. Xanthuronic acid is increased, it means B6 is deficient. Same question, they gave xanthuronic acid is increased. Yes, answer would be B6 deficiency. We found that tryptophan is normally converted to serotonin. Question is asked, precursor for serotonin is tryptophan. Question is asked, precursor for melatonin is tryptophan. Okay, serotonin is normally converted to 5-HIAA, but in carcinoid syndrome, more and more HIAA is produced. Yes, so if carcinoid syndrome is there, then tryptophan will be converted to increase HIAA. Niacin will not be formed. There would be pellagra-like symptom. So in the same question, if they gave that there is increase HIAA, the answer would become yes. You will think in your mind, yes, carcinoid syndrome. Now, you will see Sunny Leon, you will see Nia Sharma, yes, you will see car scene of PK, yes, car scene of PK, yes, हया भी नहीं आई उन्हें ऐसा सीन बनाते हुए। क्या कहा मैंने निमोनिक, ऐसा सीन बनाते हुए पीके मूवी में हया भी नहीं आई। यस, हया HIAA कार्सिनोइड, सो HIA इज देयर, yes, carcinoid is there, xanthinic acid, xanth, cross, sex, 6, okay, B6 deficiency. Now, if all these things you will hear, your heart would say nup, nup, nup. Heart nup disease is autosomal recessive. Autosomal recessive. There is defect in the absorption of tryptophan and neutral amino acid. Yes, in intestine and renal tubule. Yes. So heart nup disease, tryptophan is not absorbed. When tryptophan is not absorbed, this will lead to niacin deficiency. Niacin deficiency, yes, pellagra like symptom. So if in the same question they gave that there is defect in the absorption of tryptophan and neutral amino acid in intestine, okay, and renal tubule, the answer would become heart nup disease. Okay, so इतना सब सुन के तुमने क्या कहा। यस, तुम देखते हो वो सारे शॉर्ट्स, मजा आ गया। हाँ? और ये मजा मैं सब हिंदुस्तान के हर व्यक्ति को देना चाहता हूँ। तो ये है मेज। मेज ज्यादा मजे नहीं लेने, नहीं तो क्या हो जाएगा, पेलाग्रा। ओके, यस। So you will remember this. Now, one more question here only. B1 deficiency. Yes, B1 deficiency can be monitored by. If question is asked best monitored, yes, answer is direct measurement of thiamine level by HPLC. Recent update. Thiamine level is most commonly measured by thiamine level, most commonly measured by transketose level in blood. Most common question, transketolase. Best method to detect thiamine deficiency, that direct measurement of thiamine level in blood. Got the point? Both question has been asked recently. Now I am coming to this hexokinase and glucokinase. We found that hexokinase glucokinase both convert glucose to glucose 6 phosphate. If two for different form of enzyme catalyze the same reaction, they are called isoenzyme. So hexokinase and glucokinase are isoenzyme. Both are classified in same class, that is transferase. So hexokinase and glucokinase both catalyze the same reaction. That's why they are classified in the same class. Both are transferase. So isoenzyme are classified in the same group. Got the point? One important point is isoenzyme, they catalyze the same reaction, so they are classified in the same group. Any other property of isoenzyme may be different. Mnemonic: isoenzyme only one thing is same, they catalyze the same reaction. If they catalyze the same reaction, they are classified in the same group. Their velocity of reaction may be different, their affinity may be different, their electrophoretic mobility may be different, their protein structure may be different, their physical property may be different, their electrophoretic mobility may be different, anything may differ, but they catalyze the same reaction. So this question was asked in AIMS. True of isoenzyme. Same rate of work may be different. False. Catalyze same reaction. True. Have similar kinetics. False. Anything may be different, but they catalyze the same reaction. Quaternary structure of protein may be different. Yes. Same group of classification is used. This is true. Have similar distribution in organ distribution may be different, anything may be different, but they catalyze the same reaction. You will remember by hexokinase as helicopter. Hexokinase as helicopter. This graph question was asked. Hexokinase, how helicopter flies like this. Jet, zoom. So this is jet, this is helicopter. Okay, so graph you can recognize by the jet. If you want to travel a short distance, you will use helicopter. Again I repeat, if you want to travel a short distance, you will use helicopter. So low kilometer. Although km is Michaelis constant, for the time being I remember km as kilometer, but this is Michaelis constant. Helicopter has low km, jet is having high km. Hexokinase distribution of organ is different. Most of tissue, liver and glucokinase, liver and pancreas. Yes, organ distribution may be different, their affinity may be different, their inhibitor may be different, their activator may be different, but they catalyze the same reaction, isoenzyme. LDH1 LDH1 is usually found in heart. LDH2 is found in RBC. If you take a sample of a normal person, you will find LDH2 is more than LDH1. But in myocardial infarction, heart damage would be there, muscle damage would be there, and there will be release of LDH1. Yes, so LDH1 would become more than LDH2 in MI. This is called flipped pattern. Flipped pattern of LDH in MI. Recently asked question. Okay. Most of time answer is based on Km. Yes, glucokinase has high kilometer as compared to hexokinase. Okay, glucokinase jet has high Km. This is correct. This JIPMER question was there. Okay. Now, this is very important flow chart. I have discussed in my main class also. Now I am also repeating in a little bit faster way. Suppose whenever I take diet, in my diet carbohydrate is there, lipid is there, protein is there. Carbohydrate is the main source of energy. Whenever I take carbohydrate, carbohydrate is having multiple function. One function is to produce energy. Each and every cell want to produce energy will utilize glucose. So whenever you take food, this glucose will be used by cell by glycolysis. Glycolysis to produce energy and 2 pyruvate will be formed. Glucose will be converted to glycogen. Glucose will be converted to glycogen. Yes, extra glucose. Suppose I took lunch. After taking lunch, my blood glucose increased. As my blood glucose increased, insulin is released. Insulin want to decrease blood glucose. What I said, the only function of insulin in its life is to decrease blood glucose, the primary function. It is concerned with decreased glucose. So any reaction which decrease blood glucose will be activated by insulin. So you took food, blood glucose increased. I can take here, yes, this is blood vessel. Suppose this is blood vessel. Yes, in blood vessel, blood glucose increases and extra glucose is transferred to liver to form glycogen. Glucose is utilized by cell by glycolysis to produce energy. Yes, this extra glucose will also reach pancreas to release insulin. Okay, so after taking food, this insulin will be released. So in fed state, insulin increases. Point it out. So insulin activate glycogen synthesis, insulin activate glycolysis, insulin activate HMP shunt. One function of glucose is to produce NADPH by HMP shunt. Important point. So you remember three function of glucose. One is it is stored as glycogen. Second, HMP shunt. Third, energy production by glycolysis. In glycolysis, glucose is converted to pyruvate. Pyruvate will wait for H ion. Then pyruvate will enter the mitochondria with the help of H ion. Now pyruvate will enter the mitochondria. So whatever I am telling you, all these reactions means glycogen synthesis is occurring in cytosol. Glycogen synthesis is occurring in cytosol. Glycolysis is occurring in cytosol. HMP shunt is occurring in cytosol. So anything outside this chamber is cytosol. So all these steps, all these pathways means glycolysis, HMP shunt and glycogen synthesis occurring in cytosol. All these pathways are activated by insulin. Questions, multiple questions. Pyruvate will enter the mitochondria with the help of HN question. Okay, pyruvate is converted to acetyl coenzyme. Acetyl coenzyme enter Krebs cycle to produce energy. And question is asked: one molecule of glucose produced 10. Sorry, one molecule of glucose produce 32 ATPs by complete oxidation. Yes, one glucose. Wolman disease and glucose transporters. Glucose transporter or GLUT1 present in most of the tissue. You know, each and every cell of a body utilize glucose for the production of energy, and we found that glucose transporter 1 is widely distributed. Okay, glucose transporter 2, 2 means two-way communication. Liver, when you take food, blood glucose increases, blood glucose is transferred to liver, converted to glycogen. In between meals, liver glycogen is broken down. In between meals, liver maintain blood glucose, yes, by glycogenolysis, and glucose comes out of liver in fasting state. And the question is asked: liver glycogen can maintain blood glucose up to 16 to 18 hours. Question. A question was asked: a patient is there in the morning, you took he took breakfast, in the evening you took sample, you found the blood glucose level 180 milligram per deciliter. What is the source of this extra glucose? Means morning 8 a.m. breakfast, 8 p.m. sample, blood glucose 180 milligram per deciliter. Yes, 8 a.m., 8 p.m., 180 milligram per deciliter. So if they have given 180 milligram per deciliter, the source of extra glucose is hepatic gluconeogenesis. Gluconeogenesis means this is diabetes. In diabetes, there is gluconeogenesis. But if they don't comment, If they don't comment on 180 milligram and they simply ask at 8 p.m. blood glucose is maintained in normal person by liver glycogen, because liver glycogen can maintain blood glucose 16 to 18 hours. After 16 to 18 hours, blood glucose is maintained up to 48 hours by gluconeogenesis. Gluconeogenesis, and different tissue produce energy by beta oxidation of fatty acid. Okay, after 48 hours, it is called starvation. Then beta oxidation of fatty acid is more than gluconeogenesis. Got the point? All these are questions. Now, neuron have high affinity for glucose. 1 2 3, and I write like this: 1 2 3. Glucose transporter 3, high affinity for glucose. Even if blood glucose is very low, neuron will take that glucose and will utilize because it is having very high affinity. GLUT3. GLUT4, that mnemonic is main function. Main function of insulin. Function of insulin is to decrease blood glucose. MA, M for muscle. Muscle may be cardiac, skeletal. A for adipose tissue. And if you count, yes, M is first, second, third, fourth letter. So glucose transporter 4 is present in cardiac muscle, skeletal muscle, adipose tissue. Okay, and insulin increases the concentration of glucose transporter 4 in these tissues. Means after taking food, blood glucose increases. That increased glucose go to pancreas, and with the help of glucose transporter 2, yes, this enter the pancreas. In pancreas, insulin is released in the response of glucose, you all know. Yes, so glucose is really yes, sorry, insulin is released and insulin try to decrease blood glucose, and we found that insulin increases the glucose transporter 4 in cardiac muscle, skeletal muscle, adipose tissue. Got the point? Glucose transporter 5, F45, 5 looks like S, small intestine. Yes, F45, F for fructose. F45, yes, F looks like S, sperm. Sperm test is, seminal fluid is rich in fructose, and that fructose by glucose transporter 5. So you will remember, name is glucose transporter, but it transport fructose, glucose transporter 5. RBC uses which of the following substance during fasting and starvation? RBC has no mitochondria, so it utilizes only glucose, glucose, and glucose, nothing else. Okay, glucose. Now, glycolysis, so many questions. First question: glycolysis rate limiting enzyme is phosphofructokinase. Irreversible step catalyzed by hexokinase, phosphofructokinase, and pyruvate kinase. Okay, phosphokinase is rate limiting enzyme. Question again, I repeat, this catalyzes irreversible steps. All these other steps are reversible. All other steps are reversible. Enolase is inhibited by sodium fluoride. So whenever we take sample for blood glucose estimation, we always take sodium fluoride. Why? Because blood sample is having RBC. This RBC will utilize glucose. If you took sample in the morning and you are checking blood glucose level in the evening, meanwhile this period, yes, meanwhile during this period, RBC will utilize the glucose, and when you will measure the blood glucose, it would be falsely low. That's why we add sodium fluoride. Sodium fluoride inhibit enolase. Enolase inhibit glycolysis. And I just told you, yes, RBC totally dependent on glycolysis, and glycolysis means glucose, glucose, and glucose. Anaerobic glycolysis. Again, one more question. RBC no mitochondria, so anaerobic glycolysis. RBC anaerobic glycolysis. Now, pyruvate kinase deficiency lead to hemolytic anemia. Hemolytic Phosphatidylkinase deficiency can also lead to hemolytic anemia. But we found that phosphatidylkinase deficiency is seen in type 7 glycogen storage disease, Tourette disease. In this disease, phosphatidylkinase is deficient in RBC and muscle. If muscle is not able to produce energy by glycolysis due to deficiency of phosphatidylkinase, there would be exercise intolerance. We found normally glycolysis, glucose is converted to pyruvate. In RBC, in anaerobic condition, it is converted to lactate. So if type 7 glycogen storage disease is there, pyruvate kinase deficiency is there, hemolytic anemia would be there, but these steps are not occurring, so lactate will not be produced. So in both hemolytic anemia, lactate level would be low. A frequently asked question, G6PD deficiency, G6PD deficiency, NEET 2022. Question was asked. They asked that there is a patient was given primaquine. You know that after giving these drug, patient presented with hemolytic anemia and oxidizing agent. Hemolytic anemia patient presented with they asked which the enzyme deficient is involved in which pathway. The answer was HMP shunt. So G6PD is enzyme of HMP shunt. This question was recently asked, and now we know that G6PD deficiency lead to hemolytic anemia. Most common enzyme deficiency most common enzyme deficiency leading to hemolytic anemia. Pyruvate kinase, second most common enzyme deficiency leading to hemolytic anemia. This is HMP shunt. HMP shunt, a question recently asked, HMP shunt give rise to NADPH question. HMP shunt produce pentose sugar question. HMP shunt also produce acetyl coenzyme A. Yes, HMP shunt ultimately lead to glyceraldehyde 3-phosphate. Glyceraldehyde 3-phosphate can enter glycolysis to produce pyruvate. Yes, glyceraldehyde 3-phosphate enter glycolysis, a intermediate of glycolysis to produce pyruvate. Pyruvate, yes, in mitochondria. Pyruvate in mitochondria is converted to acetyl coenzyme A. So HMP shunt glucose ultimately converted to acetyl coenzyme A. Yes, may be converted. This was the question. Okay. This topic is very important. Yes, question was asked, glutathione reductase activity, yes, is decrease in B2 deficiency. B2 FAD is cofactor for glutathione reductase, and this activity is glutathione reductase activity is decrease in B2 deficiency. Glutathione peroxidase prosthetic group is selenium. Old question. Nowadays, we started saying selenocysteine 21st amino acid present in glutathione peroxidase. Other enzyme, deiodinase, thioredoxin reductase. These are enzymes in which selenium as cofactor or prosthetic group, or selenocysteine 21st amino acid is there. Deficiency of selenocysteine lead to Cashin disease, and this is cardiomyopathy is there. Recently asked question. Okay. Now, a middle-aged woman presented with fissure in mouth, tingling sensation. Investigation showed reduced glutathione reductase activity. Yes, B2 deficiency lead to reduced glutathione reductase activity. B2 deficiency, riboflavin, there is chillosis, magenta color tongue, keratitis may be there. Okay, tingling sensation may be there. I usually tell mnemonic. Yes, you just imagine, fantasize. Yes, a magenta color ribbon. Why I said ribbon? Because B2 is riboflavin ribbon. Okay, and you can fantasize so many things with the help of ribbon. Yes, blindfold, keratitis, chillosis. Yes, you know better. Okay, now in this question you can tell me answer very easily. 33-year-old man presented with symptom of weakness, fatigue, shortness of breath, dizziness. These are common symptom in medicine practice. Hemoglobin is 7, means there is anemia. Hemolytic anemia may be there. In this question, they have given four options. All enzymes deficiency, most of them lead to hemolytic anemia. We have discussed pyruvate kinase deficiency lead to hemolytic anemia. Pyruvate kinase deficiency lead to hemolytic anemia. G6P deficiency lead to hemolytic anemia. And in these two, lactate would be low. Lactate is low. So in this question, they have given low level of lactate production. Yes, lactate level low, low level of lactate production. So there would be, answer would be pyruvate kinase. But in the same question, they gave patient is also having exercise intolerance. Yes, in phosphofructokinase type 7 glycogen storage disease, there would be exercise intolerance. So the same question answer is pyruvate kinase. In the same question, if they gave there is exercise intolerance, the answer would become phosphofructokinase. In the same question, if they say that lactate level is high lactate, then G6PD deficiency. In G6PD deficiency, what would happen if G6 is deficient? HMP shunt would not occur. If HMP shunt would not occur, more and more glucose in RBC will go to glycolysis and will produce lactate. You know, RBC, there is a no aerobic glycolysis, only and only anaerobic glycolysis. So if in RBC HMP shunt is not occurring, more and more glucose will produce lactate, lactic acidosis, or increase lactate, better to say increase lactate in RBC. Okay, so if high lactate level, then G6P deficiency. So this is about HMP shunt. Glycolysis questions are asked. Now, glycolysis and gluconeogenesis are two opposite pathway. Glucose to pyruvate is called glycolysis. Pyruvate to glucose is called gluconeogenesis. These are two opposite pathway. These are regulated in such a way when one is activated, other is kept in inhibited state. Now, remember point. A question was asked in NEET pattern 19. Yes, that enzyme common to glycolysis and gluconeogenesis. All enzymes of glycolysis, right? This all enzymes of glycolysis involved in gluconeogenesis, except hexokinase, phosphofructokinase, and pyruvate kinase. Hexokinase, phosphatokinase, and pyruvate kinase. So this phosphoglycerate kinase is involved in gluconeogenesis. Glyceraldehyde 3-phosphate dehydrogenase is involved in gluconeogenesis. All enzymes of glycolysis involved. Recently asked question. Now I will draw a flow chart. Yes, glucose, glucose to, I write here, glucose to pyruvate, that is glycolysis. Pyruvate to glucose, gluconeogenesis. Yes, glucose to glycogen, glycogen synthesis. Glycogen to glucose, glycogenolysis. You all know. Yes, I write here again acetyl coenzyme A, acetyl coenzyme A to fatty acid, that is fatty acid synthesis. Fatty acid to acetyl coenzyme A, beta oxidation of fatty acid. These are three opposite pathways. These are regulated in such a way when one is activated, other is kept in inhibited state. And I have already told you that insulin activate glycolysis. Insulin activate glycolysis. So insulin will inhibit gluconeogenesis. Insulin activate glycogen synthesis. So yes, insulin will inhibit gluconeogenesis. Insulin activate fatty acid synthesis. So insulin will inhibit beta oxidation of fatty acid. These are two opposite pathways are regulated in such a way when these three are regulated by insulin, activated by insulin, these three are inhibited by insulin. and their enzymes are inhibited and activated in such a way you will remember. Yes, you will remember one important point: insulin insult phosphate means insulin remove phosphate, insulin remove phosphate. If you insult anybody, definitely he will be gone, or he will leave, or she will leave. Insulin remove phosphate. Okay, and activate enzyme, and activate enzyme. So any enzyme which are activated by insulin are active in dephosphorylated state. Enzymes of these three pathway are active in dephosphorylated state. All these enzymes of these pathway are active in dephosphorylated state, because these pathway enzymes are activated by insulin. Insulin remove phosphate, so all these three pathway enzymes are activated by insulin and active in dephosphorylated state. Frequently asked question. Okay, now, I told you pyruvate enter the mitochondria with the help of HNs import. Pyruvate is converted to acetyl coenzyme A by pyruvate dehydrogenase. E1 is pyruvate dehydrogenase. In this, what happens? Pyruvate is having how many carbon? 3 carbon. Pyruvate is having 3 carbon. 3 carbon compound is converted to carbon. CO2 is removed. That is done by pyruvate dehydrogenase. Okay, this acetyl coenzyme is produced, and in this we found that NAD is converted to NADH, and removal of hydrogen is called oxidation. This is oxidation, this is decarboxylation. So pyruvate is converted to acetyl coenzyme A by oxidative decarboxylation, and oxidative decarboxylation of alpha keto acid. Yes, oxidative decarboxylation of alpha keto acid cofactor is vitamin B1. So these three enzyme cofactor is vitamin B1. Wherever FAD is there, cofactor is B2. In biochemistry, wherever NAD is there, cofactor is B3. Coenzyme cofactor is B5, lipoic acid. All these cofactors are, yes, B1, B2, B3, B5, lipoic acid are cofactor for these three enzymes. Yes, and these are also cofactor for Krebs cycle. These are also cofactor for Krebs cycle. Recently asked question Jipmer. Otherwise healthy, lethargic in some prescribed vitamin supplement, diet, boost energy, metabolism, play important role in citric acid cycle. Yes, citric acid cycle. Why I am taking this JIPME question? We found that many time. Yes, if you see the history, JIPME questions are repeated in All India NEET after 3 4 years. This is a common practice. Okay, so in this thiamine B1, riboflavin B2, niacin B3, pantothenic acid B5. These are cofactor for Krebs cycle. Okay. Now, urea cycle, you will remember each and every step. CO2 bind with ammonia to form carbonyl phosphate. Bicarbonyl phosphate synthetase 1. If this enzyme is deficient, then it is called hyperammonemia type 1. If carbonyl phosphate, how to remember? Yes, C4CO2, C4 carbonyl phosphate, C4 citrulline. Now CCC. Carbonyl phosphate bind with ornithine by enzyme ornithine transcarbamylase. If this enzyme is deficient, then it is called hyperammonemia type 2. This is most common enzyme deficiency in urea cycle. Most common enzyme deficiency of urea cycle. In this, what will happen if this step is not occurring? Carbonyl phosphate will come out of the mitochondria, and in cytosol it will take part in pyrimidine synthesis. Pyrimidine synthesis. In pyrimidine synthesis, carbonyl phosphate is converted to orotic acid urea. So type 2 hyperammonemia, clinical questions are asked, they give orotic acid urea, and you mark the answer ornithine transcarbamylase very easily. So this citrulline transporter transfer citrulline outside. Citrulline bind with aspartate, mnemonic AS. Whenever aspartate join A4-argino S4-succinate, arginosuccinate is formed. This arginosuccinate is converted to arginine and fumarate by arginosuccinate lyase. Arginosuccinate lyase. Now, before moving further, this fumarate. Fumarate is produced in urea cycle, and fumarate is intermediate of Krebs cycle. Yes. So question was asked, connecting link between urea cycle and Krebs cycle. Connecting link, connecting link between urea cycle and Krebs cycle. Answer was fumarate. But you will remember that this is aspartate. If you deaminate aspartate, it will become oxaloacetate. And oxaloacetate is intermediate of Krebs cycle, yes or no? Yes, oxaloacetate is also intermediate of Krebs cycle. So a question was asked, connecting amino acid, point it out. If connecting link, fumarate. Connecting amino acid, if they ask connecting amino acid, the answer would be aspartate. Clear? Now, little bit faster. Hyperammonemia type 1 CPS1 is deficient. Type 2 OTC, ornithine transcarbamylase is deficient. Citrullinemia, not SUT2. Yes, citrullinemia. Yes, arginosuccinate synthase, or better to say synthetase, in this two ATPs are used. So ATP, whenever ATPs are used, the enzyme is synthetase. So arginosuccinate synthetase is deficient, then citrulline will not be converted to arginosuccinate. Citrulline will increase. That's why citrullinemia. Okay. Sometimes there is defect in citrulline transport. Citrulline transporter is defective. Then it is again will lead to increased citrulline. That is called citrullinemia type 2. Okay. Triple H syndrome. Triple H syndrome. If ornithine, this arginine is converted to ornithine. Yes, I think that you have attended my regular class, so it would be easier for you to recall. Yes, I'm not going in depth. Yes, ornithine is normally transported to mitochondria by this ornithine transporter. If ornithine transporter is deficient or defective, then the triple H disease. Okay, hyperammonemia, hyperornithinemia, hyperhomocystinemia. Okay, arginosuccinic acid urea. Yes, arginosuccinase deficient. Hyperarginemia, arginase deficient. Most of the time, whenever questions are asked, you will find that these questions are easily solved. These questions are easily solved by only one thing. Okay. These questions are only solved by, if you remember these steps of these pathway. Steps of these pathway, if you remember, it can be solved very easily. Okay, dear friends. Now, yes, glycogen storage disease, very important topic. I will say glycogen storage disease of two type. One is liver glycogen storage disease, second is muscle glycogen storage disease. We will remember this flow chart. Glycogen storage disease may be of two type: muscle glycogen storage disease, liver glycogen storage disease. If liver glycogen is not metabolized properly, this glycogen will accumulate in liver. Yes, and will not be able to contribute blood glucose. I told you up to 16 to 18 hour blood glucose is maintained by liver glycogen. But if liver glycogen is not metabolized properly, that blood glucose will not be maintained. There would be fasting hypoglycemia. In between meal, patient will present with fasting hypoglycemia. This glycogen will accumulate, ultimately liver, yes, will enlarge hepatomegaly. Most of time you will find whenever hepatomegaly is there, many times we do biopsy. Yes, whenever we do biopsy, we found that liver glycogen accumulation is there. Glycogen is accumulated. We will check the shape, structure of glycogen. Structure of glycogen may be normal or abnormal. So Liver glycogen storage disease, patient presented with fasting hypoglycemia, hepatomegaly. You took liver biopsy, liver glycogen was abnormal. If abnormal glycogen is there, it may be either Anderson disease or Cory's disease. Simple concept. A, B, C, D. A for Anderson, A for, yes, Anderson disease, A. B for branching. So Anderson disease, which enzyme is deficient? Branching enzyme is deficient. C for Cory's disease, yes. D for debranching enzyme. In both of these glycogen storage disease, there is accumulation of abnormal glycogen. Cory's disease, there is accumulation of limit dextrin. Limit dextrin. That's why Cory's disease also called limit dextrinosis. Cory's disease cures itself, cures itself. Mnemonic means many times you will find this child or this patient will, when will reach adolescence, these symptom will go. Okay, Cory's disease cures itself. And another name of Cory's disease is 4B's disease. Why I am pointing out it very nicely here? 4B, 4B, you will remember before 4 means third. Because questions are asked Farber, Fabry's. Farber, ceramidase is deficient. Fabry's, alpha galactosidase is deficient. 4B's, yes, debranching enzyme is deficient. All these three are questions. Anderson disease, Anderson, end of son, son will die. Yes, death by fourth year, death by fourth year, also called amylopectinosis, amylopectinosis. Okay, amylopectinosis. If on biopsy glycogen is normal, it may be von Gierke's disease or Huss disease. Von type 1 glycogen storage disease, glucose 6 phosphatase is deficient, and in this there is characteristic renomegaly, and other than renomegaly, lactic acidosis, gout. Okay, Huss disease, liver phosphorylase is deficient, liver phosphorylase deficiency. If this is deficient, Huss disease, liver phosphorylase deficient, then liver glycogen will not be metabolized, will accumulate, and there would be fasting hypoglycemia, hepatomegaly. Okay, no renomegaly, lactic acidosis, you can differentiate. Muscle glycogen storage disease, you know that muscle can't do exercise without energy. If muscle glycogen metabolism is defective, there would be exercise intolerance. And if in question of glycogen storage disease, if you find hypertrophic cardiomyopathy, sometime chest x-ray you will find there is enlarged heart, hypertrophic cardiomyopathy, then it is, yes, Pompey's disease. Pompey's disease. You know, heart pumps the blood. Heart pumps the blood. Pompey's disease, death occurred due to heart failure. Death occurred due to heart failure. Okay, heart failure or pump failure, pump failure. Okay, now you can solve question. 2-month-old infant, generalized muscle weakness, floppy infant. In this hypertrophic cardiomyopathy is there, Pompey's disease. Yes, in this question, yes, patient is having multiple symptoms and he reached normal adult height. Yes, there is no longer has hypoglycemia, muscle weakness, hepatomegaly, means yes, cures itself. Cory's disease, Cory's disease. Clear? So this is glycogen storage disease, different types of glycogen storage disease. One, von Gierke's, O1, von Gierke's, Pompey's type 2, acid maltase deficient, yes, type 3, Cory's disease, CD, debranching, Anderson disease, amylopectinosis, branching enzyme is deficient, McArdle M4 muscle phosphorylase is deficient. Two times question has been asked, muscle phosphorylase deficient, they gave clinical symptom, patient is having exercise intolerance, what is the diagnosis? Yes, the answer was McArdle. Recently question was asked that muscle phosphorylase, the activator is calcium. Yes, you know, whenever we do exercise, we require energy. Energy is can be produced in muscle by muscle glycogen. Muscle says myself. Yes, muscle glycogen is used by muscle only. And whenever you are running, yes, muscle came to know that now you will require glycogen. So that's why nature thought better to make calcium as the activator of phosphorylase. So whenever you will start exercise, calcium will be released from sarcoplasmic reticulum. It will activate muscle phosphorylase and glycogen will be broken down to maintain energy. So calcium is activator of muscle phosphorylase. Heart disease, hepatic phosphorylase. Yes, galactosemia, I will discuss shortly. Hereditary fructose intolerance, essential fructose urea. At least you must remember the name of enzyme. Essential fructose urea, fructokinase is deficient. Hereditary fructose intolerance, aldolase B is deficient. Galactosemia, galactose 1 phosphate uridyl transferase is deficient. Clear? Yes, this question you can see in this kidney are enlarged. This is specific of rhenomyelin is specific of type 1 glycogen storage disease. Okay. Galactose metabolism, if galactokinase is deficient, there would be accumulation of galactitol in lens. This is called oil drop cataract seen in galactokinase deficiency. Only and only cataract would be there. If galactose 1 phosphate uridyl transferase deficient, this is called classical type of galactosemia. Classical type of galactosemia. This in this patient, galactose 1 phosphate will accumulate. Yes, if this enzyme is not working, this galactose 1 will phosphate will accumulate and will inhibit glycogenolysis. Glycogen will not be broken down. This galactose 1 phosphate inhibit glycogenolysis. So there would be fasting hypoglycemia, hepatomegaly. So fasting hypoglycemia, hepatomegaly, we have learned fasting hypoglycemia, hepatomegaly. If you take liver biopsy, you will find the accumulation of glycogen. This phenomena, this thing can be present in galactosemia also. But in this, what would be the difference? In this patient is usually present with symptoms after taking breast milk, because milk is made up of glucose and galactose metabolism is defective. That's why patient would not be able to metabolize galactose and symptom will precipitate after feeding. One point. Second, in galactose is very high will come in urine, and urine galactose will give Benedict test positive. So relation with breastfeeding, one point. Second, Benedict test positive. Got the point? So this is galactosemia. Now, a 3-week-old neonate who began vomiting after 2 days after birth, usually within 30 minutes after breastfeeding. Means after breastfeeding, relation with breastfeeding, there would be enlargement of liver, hepatomegaly, jaundice. Yes, during depistic test, glucose was negative. Test for reducing sugar was positive. Galactose is reducing sugar. Galactose is reducing sugar will present in urine because galactose metabolism is defective. Galactose will come in urine. So urine depistic test will be positive for galactose. So answer is classical galactosemia. Got the point? Now, sorbitol pathway. Yes, if diabetes is there, more and more glucose will be converted to sorbitol. Sorbitol will accumulate in lens to produce snowflake cataract. So snowflake cataract due to abnormality or defect in sorbitol pathway, you can say. Or in diabetes, blood glucose is high, sorbitol pathway is involved. One question they can ask. Yes, this is integration. They will give you that all the symptom of galactose metabolism, and they will ask you that for which or this patient presented with sepsis, which organism usually cause sepsis in classical galactosemia. Yes, the answer is, you think in your mind, E. coli. these patients of classical galactosemia are, yes, predisposed to sepsis by E. coli, septicemia by E. coli. Yes, before moving further, yes, essential fructose urea is patient is asymptomatic. Aldolase B deficiency, hydrofructose intolerance, again patient is having hepatomegaly. Yes, in galactosemia there was hepatomegaly. In hydrofructose intolerance, hepatomegaly. Fasting hypoglycemia, fasting hypoglycemia. So how you will differentiate? Urine reducing sugar present, urine reducing sugar present. What is the difference? Yes, in history, patient will present after breastfeeding, early part of infancy. In this, patient will present after weaning. Weaning usually start at 4 to 6 months. Yes, according to now new guidelines, there should be exclusive breastfeeding up to 6 months. Okay, but even now you will find that many parents start giving extra food to newborn, and whenever they start weaning, fructose will come in diet and patient will present with these symptoms. So history is very important. Parents will tell Dr. Saab, child was doing pretty well, but when we start giving fruit juice, yes, weaning we started, patient presented with these symptoms. So history is typical. Fatty acid synthesis always have been an important topic. Yes, fatty acid synthesis, extra carbohydrate is converted to fatty acid. First and rate limiting step is acetyl coenzyme is converted to malonyl coenzyme. A two carbon compound is converted to three carbon compound by acetyl coenzyme carboxylase. Acetyl coenzyme carboxylase. Yes, this is rate limiting enzyme. Recently asked question. Yes, rate limiting enzyme. If this malonyl coenzyme is inhibitor of CPT1, question, is inhibitor of yes, succinate dehydrogenase, question, is inhibitor of complex second of electron transport chain, question. Okay, what is CPT1? I will discuss shortly. For the time being, in fatty acid synthesis, extra carbohydrate is converted to fat. First rate limiting enzyme is acetyl to malonyl coenzyme. Further synthesis take place on fatty acid synthase complex. Question is asked, this is multi-enzyme complex. Multi-enzyme complex. 6 enzymes are there. Yes, and in this fatty acid synthesis occur, sequence of enzyme is reductase, hydratase, reductase. Remember this point, reductase. And whenever you want reduction, you require NADPH. NADPH. And NADPH is produced by, yes, HMP shunt. HMP shunt. A question was asked that if HMP, yes, if G6PD is deficient, what is the primary pathway which is affected? If G6PD is deficient, I have discussed, if G6PD is deficient, then HMP shunt would not be there. In HMP shunt, first and rate limiting step is G6 catalyzed by G6PD. Or if G6PD is deficient, HMP shunt would not be there. When HMP shunt would not be there, then NADPH will not be produced. When NADPH will not be produced, then fatty acid synthesis will be affected. So they ask question, in G6P deficiency, primary pathway affected is HMP shunt. Secondary pathway affected is fatty acid synthesis. Clear? So de novo synthesis of fatty acid steps are, yes, what are the steps? First, requirement of acetyl coenzyme. Yes, acetyl coenzyme is required. Yes, production of malonyl coenzyme. This is rate limiting step. I told you, by acetyl coenzyme carboxylase. Acetyl coenzyme carboxylase. Carboxylase required biotinase cofactor, question. Elongation of chain. By fatty acid synthase complex. This is multi-enzyme complex. This is multi-enzyme complex. Yes, contains 6 enzymes. Malonyl coenzyme is a style donor and it require NADPH and acetyl coenzyme. This reaction, fatty acid synthase occurring in cytosol. Fatty acid synthase occurring in cytosol. Got the point?